patients with HIV hepatitis C co-infection, and interim analysis of a French multicenter compassionate use program. Do you want that?
Good afternoon, ladies and gentlemen. I will present today the interim analysis of a French multicenter compassionate use program of Daclatasvir plus sofosbuvir for HIV co-infection. Here are my disclosures. As you all know, Daclatasvir is a pangenotypic NS5A inhibitor, well-tolerated, orally available, and in addition with sofosbuvir, the combination has been tested in HIV-infected patients and achieved a high rate of SVR of 97% in patients receiving a wide range of antiretroviral agents. The French Compassionate Use Program, CUP, provided Daclatasvir before commercialization from March to October 2014 in HCV-infected patients without available treatment option and advanced liver disease. Daclatasvir was recommended at 60 milligrams daily with sofosbuvir for 24 weeks, and the dose was adjusted in case of boosted PI or NNRTI except ribavirin. Ribavirin could be used and a shorter duration could be prescribed at physician discretion. The aim of this interim analysis is to evaluate the efficacy and the safety in the subset of HIV-HCV co-infected patients. Let's go a little more in the definition of the indication of this CUP. It was for advanced liver disease defined by a METAVIR score of at least F3 or extrahepatic manifestation or recurrence of HCV post-liver transplantation or a patient with an indication for liver or kidney transplantation. As usual, there was some contraindication in case of pregnancy, allergy, or strong inducers. We had two endpoints. The first was the sustained virologic response at post-treatment week 12, and the second one was safety assessed by adverse event, either severe or leading to discontinuation. For this interim analysis, we defined three populations. The first was the primary efficacy population, as observed, and concerned all patients with available HCV RNA assessment at post-treatment dose 12. The second one was a sensitivity analysis population, concerning all the above population, plus the patient with HCV RNA detectable at post-treatment 4 visit, but without available data at post-treatment 12 visit. Those patients were also considered as failure at post-treatment 12. And for the safety population, as requested by the health authority, we included all the patients who had at least one visit under treatment. Here is a baseline characteristic of the population in the as observed analysis. The majority of the patients were male and serotic in 3/4 of the patients. 50% of them were infected by the genotype 1A, then genotype 4, genotype 1B, and 10% harbor a genotype 3. The dose of Daclatasvir was 60 milligrams in 60% of the case, and decreased to 30 milligrams in 1/3 of the patient. The duration of the treatment was, as recommended, 20 weeks for 68% of the patient, but shortened to 12 weeks in 31% of the patient. And ribavirin was used only in 10% of the patient. Concerning the HIV characteristic, you can see that the patients were well controlled with a comfortable CD4 cell count of about 600 and received a wide range of antiretroviral, since 35% receive a protease inhibitor, 64% an integrase inhibitor, and less often an NNRTI. Here is the overall success rate in the as-observed analysis. The rate is of 97%. You can see that with Daclatasvir and sofosbuvir, there was no difference between the 12-week and the 24-week duration, and also that the rate of success with ribavirin, also the number of patients is very low, does not seem different than without ribavirin. Here is a sensitivity analysis. You remember that in this analysis, we added 12 patients who had HCV RNA positive at post-treatment 4, but with no result available at post-treatment 12. The rate of success is decreased around 90%, but the trend are the same. It seems there is no difference between 12 weeks and 24 weeks, and no benefit apparent of the addition of ribavirin. Here are the SVR rates with genotype and cirrhosis status. You can see that the rates are similar, whatever the genotype, 1, 3, or 4, and also are similar for patients with cirrhosis. As we had an important subset of patients, cirrhotic and of genotype 1, we looked if there was an apparent difference with patients taking ribavirin or an extended duration of therapy, and as you see on the back of the slide, there was no apparent benefit of ribavirin use or longer treatment. In the sensitivity analysis, as previously presented, the rates are a little slower. We observe a total, it is still an interim analysis, but currently we have 15 failures. The majority of these failures are relapses and are seen in all genotypes, more in genotype 1, but it's only because we have more patients in this subgroup, and 2 virological breakthrough. And for 4 patients, the data are still missing. Here is now the safety. So the safety is on the total population of more than 500 patients receiving at least 1 dose. We observed 9 deaths. 7 of the deaths were not related to the treatment, and for 2, the data are missing. 2 severe adverse events linked to HCV therapy. 1 patient had a bundle branch and has to get a pacemaker placement, and another one had an important CPK increase, but both continue their treatment. 20 events non-related to therapy for the physician, and 2 discontinuation due to adverse events that were in both cases asthenia. There was no compromise of HIV control and a stable CD4 cell count and HIV control. In conclusion, sofosbuvir and Daclatasvir provided in this CUP program, in the real-world situation, high SVR rate in HIV-HCV co-infected patients. There was no benefit of extending duration from 12 to 24 weeks, no apparent benefit of the addition of ribavirin, and the results of the sensitivity analysis, also lower, show similar trend to the observed analysis. We think that the reality will be in between 90% and 97%, but we have a lot of data that are still to be collected. We observed comparable SVR rates regardless of genotype and cirrhosis status, and generally the regimen was well tolerated, and the main thing, it was compatible with a wide range of antiretroviral agents. There were no compromise of HIV control. And finally, we think that these results of real-world add data on severe liver disease and are consistent to the results of Ally2 study that is, by the way, published online also today in the New England. I finally would like to really thank the patients, their family, all my colleagues, pharmacists, medical staff, and the EPAVI cohort who contributed also to this study. Thank you very much.
So thank you for that while we're waiting for questions. Just for my clarification, And so that we can interpret
Yes.
these results in the context of the ION4 and the Merck and the Ally 2 study. Can you just clarify what the intent to treat SVRs were for genotypes 1, 3s, and 4s? Because I think you were presenting
Yes.
on protocol.
In fact, this interim analysis was based on all the results available for the patient at SVR 12. You know, because the data, it's not a trial nor a cohort. The physicians, they send the form, but they are not, it's not mandatory. So we have data, we have to interpret them. So we cannot put as failure the data missing yet, you know. But
Okay.
as soon as we have positive HCV RNA under treatment or before SVR12, it is a failure, you know. But for the data that are missing, it's too early to say that it's a failure or a
Sure.
success.
Yep, fair enough.
You understand?
Okay, just important to keep that in mind
Yes.
in interpreting the results.
Dominic, thank you very much. Sanjay Pagani, they're all free. Great data, and it's really nice to see some real-world data that kind of confirms what we know already. Just a quick question. Do you know what percentage of your patients with cirrhosis had either evidence of decompensated disease or had child B or C cirrhosis? The only reason I ask that is because in the NHS Expanded Access Program, we certainly found a difference in terms of adding ribavirin to that small group of very advanced fibrotic cirrhotic patients. So it sounded like we didn't have many of those in this study. Could you make a comment on that, please?
Yes. Thank you for this question. It's certainly very interesting. I just know that we have 3/4 of the patients that are cirrhotic, and among the cirrhotic, we have 85% that are child A. But I didn't look profoundly if there was a difference between child A and child B and C. Certainly, it's something to do. Thank you.
Okay, well, I think that concludes our session. I want to thank all the speakers,